one is Dr. Nina R.
So very warm good morning to one and all. No financial interest. So as we know, when light falls on the retina, it's first picked up by the photoreceptors, then it goes to the bipolar cells, then the retinal ganglion cells, and from there, the axons of the retinal ganglion cells form the optic nerve, and from there it goes to the optic chiasma, and then to the tract, then finally relays at the lateral geniculate body, goes to the optic radiation and to the occipital lobe of the visual cortex, and that's where the vision is processed. So we know that the retinal ganglion cells are the only output neurons from the retina, and a lesion anywhere along this pathway of the retinal ganglion cells can result in cell death and can be picked up in the retina with the OCT. So this is the picture of the course of the retinal ganglion cells across the retina, maximum concentration in the perifoveal region with absence at the fovea itself, and this is a beautiful picture of the OCT showing the quantification of the retinal layers. So the aim of a study was to see if we are able to understand the pattern, if you're able to correlate the macular ganglion cell loss as seen on OCT and correlate it with the neuro-ophthalmic findings and the visual field changes. And this was done in patients coming to a tertiary eye care center with neuro-ophthalmic disease. So we picked up retrospectively, we picked up 5 cases of optic neuritis, non-arthritic anterior ischemic optic neuropathy, pituitary macroadenoma, idiopathic intracranial hypertension, and PC infarct, and try to correlate the clinical findings with the investigations, neuroimaging, and the macular GCN analysis as done on SD-OCT with a Heidelberg machine. So first case was an 18-year-old college student who came to us with sudden onset of blurred vision left eye, 6:45 N36 with RAPD in the left eye. And you can see in the fundus, she had a hyperemic blurred disc in the left eye. The VEP showed a reduced amplitude and a prolonged latency in the left eye. And the visual fields showed a dense nasal scotoma and some inferotemporal visual field defects. The OCT of the RNFL showed some non-specific temporal thinning, but look at the GCL. It showed a corresponding temporal and supranasal thinning, corresponding exactly to the field defects. And her diagnosis of optic neuritis was confirmed on the MRI, showing a thickened and hyperintense optic nerve with post-contrast enhancement. The second case is that of a 55-year-old man with labile hypertension, defective vision, N36, near vision with poor distant vision, RPD again, and the disc showing a feature suggestive of non-arthritic anterior ischemic optic neuropathy. Look at the visual fields, an inferior altitudinal defect, see the GCL, superior GCL thinning corresponding exactly to the altitudinal defect, whereas the RNFL just showed an inferotemporal edema, which was misleading. Coming to the third case, a 45-year-old lady with gradually progressive vision loss. Everything was normal, vision, anterior segment, fundus, but bitemporal hemianopia, and look at the GCL, binasal GCL thinning corresponding exactly to the bitemporal hemianopia, whereas the RNFL did not show any specific changes, and she had a stellar mass compressing the chiasm. The fourth case is the 32-year-old housewife with chronic headache. Vision was normal, but fundus showed papilledema, established papilledema, RNFL edema on OCT. Fields were normal, GCL was normal. Now what's the role of GCL here? When you give treatment for idiopathic intracranial hypertension, the edema comes down. We are in a doubt whether it's due to progressive optic atrophy happening or due to the edema actually decreasing. Monitor the GCL with this. A stable GCL assures you that patient is improving clinically. Now the last case is a 68-year-old hypertensive and diabetic with recent complaints of hitting objects on the left visual field. Vision was normal, fundus was also essentially normal, but look at the visual fields, left homonymous hemianopia, and look at the GCL, exact right-sided nasal thinning of the GCL mapped on OCT corresponding to the visual field effect, whereas RNFL was within normal limits. And as expected, he had a right-sided infarction of the parieto-occipital cortex, which was responsible for his hemianopia. So what I would like to point out is that MGCN analysis has a better correlation with the visual field changes than with the PPRNFL analysis, and this was shown in many studies by many previous authors. And to conclude, MGCL may have a direct correlation to the vision field loss. It's an effective tool in diagnosing, monitoring, prognosticating neuro-ophthalmic conditions, especially when visual fields are not feasible due to low vision or poor cooperation. Thank you very much.
Thank you, Dr. Nina.